series of tightly choreographed events involving the primordial germ cells, the Mullerian paramesomphric ducts, the Wolffian mesomphric ducts, and the urogenital sinus fig. 22.1. Germ cells arise in the wall of the yolk sac by the 4th week of gestation. By the 5th or 6th week, they migrate into the urogenital ridge and induce proliferation of the mesodermal epithelium, which gives rise to the epithelium and stroma of the ovary. The lateral Mullerian ducts form at about the 6th week of development through invagination and fusion of the coelomic lining epithelium. The ducts progressively grow caudally into the pelvis, where they swing medially to fuse with the urogenital sinus at the Mullerian tubercle C fig. 22.1a. Further caudal growth brings these fused ducts into contact with the urogenital sinus. The unfused upper portions of the Mullerian ducts mature into the fallopian tubes, while the fused lower portion develops into the uterus, cervix, and upper vagina. The urogenital sinus develops when the cloaca is subdivided by the uroctal septum. It eventually forms the lower part of the vagina and the vestibule of the external genitalia C fig. 22.1b. The mesomphric ducts normally regress in the female, but remnants may persist into adult life as epithelial inclusions adjacent to the ovaries, tubes, and uterus. In the cervix and vagina, these rests may be cystic and are termed Gartner duct cysts. The epithelial lining of the female genital tract as well as the ovarian surface share a common origin from coelomic epithelium mesothelium, which may explain why morphologically similar benign and malignant lesions arise in various sites within the female genital tract and the adjacent peritoneal surfaces. Diseases of the female genital tract are extremely common and include complications of pregnancy, infections, tumors, and hormonally induced abnormalities. The following discussion presents the pathology of the major diseases that result in clinical problems. Additional details can be found in current textbooks of gynecologic pathology and clinical obstetrics and gynecology. We will discuss the pathologic conditions peculiar to each segment of the female genital tract separately. But before doing so, we will briefly review infections and pelvic inflammatory disease because they can affect many of the various anatomic structures concomitantly. Infections. A large variety of organisms can infect the female genital tract. Some infections with microorganisms such as Candida, Trichomonas, and Gardnerella are very common and may cause significant discomfort, but are without serious sequelae. Others, such as Neisseria gonorrhoeae and chlamydia infections, are major causes of infertility, while organisms such as group B streptococcus infections are implicated in preterm deliveries, stillbirths, and neonatal infections. Viruses, especially herpes simplex viruses HSVS and human papillomaviruses HPVS, also account for considerable morbidity. HSVs cause painful genital ulcerations, whereas HPVs are involved in the pathogenesis of cervical, vaginal, and vulvar cancers described later. Many of these infections are sexually transmitted, including trichomoniasis, gonorrhea, mycoplasma, chlamydia, HSV, and HPV, as well as less common infections such as syphilis, chancroid, granuloma inguinale, and lymphogranuloma venereum. Most of these conditions are considered in Chapter 8. HPV is also discussed in Chapter 7 due to its importance. Mesomphros, ovary, fembri suspensory ligament of ovary, ovarian ligament proper, mesovarian broad ligament, Mullerian duct, mesomphric, remnants corpus body, mesomphric duct, A, Mullerian tubercle, urogenital sinus, uterine canal, B, mesomphric, remnants, cervix fornix vagina. Figure 22.1 Embryology and anatomy of the female genital tract. Early in development, the mesomphric blue and Mullerian red ducts merge at the urogenital sinus to form the Mullerian tubercle. B. By birth, the Mullerian ducts have fused to form the fallopian tubes, uterus, and endocervix red, merging with the vaginal squamous mucosa. The mesomphric ducts regress, but may be found as a remnant in the ovary, annexin, and cervix Gartner duct cysts. Modified from Lama J. Medical Embryology, Baltimore, 1981, Williams and Wilkins. 9. The Isoniatyphnos 789, role as a transforming virus. Here we touch only on aspects relevant to the female genital tract, including pathogens confined to the lower genital tract vulva, vagina, and cervix, and those that involve the entire genital tract and are implicated in pelvic inflammatory disease. Infections of the lower genital tract. Herpes simplex virus. Genital herpes simplex virus HSV infection is common and may involve the vulva, vagina, or cervix. HSVs are DNA viruses that include two serotypes, HSV1 and HSV2. HSV1 typically results in perioral infection, whereas HSV2 usually involves genital mucosa and skin. However, depending on sexual practices, HSV1 may be detected in the genital region and HSV2 may cause oral infections as well. Chapter 8. By 40 years of age, approximately 30% of women are seropositive for antibodies against HSV2. About 1/3 of newly infected individuals are symptomatic. Lesions typically develop 3 to 7 days after transmission and are often associated with systemic symptoms such as fever, malaise, and tender inguinal lymph nodes. The earliest lesions usually consist of red papules that progress to vesicles and then to painful coalescent ulcers. The lesions are easily visible on vulvar skin and mucosa, while cervical and vaginal lesions present with purulent discharge and pelvic pain. Lesions around the urethra may cause painful urination and urine retention. The vesicles and ulcers contain numerous viral particles, accounting for the high transmission rate during active infection. The mucosal and cutaneous lesions heal spontaneously in 1 to 3 weeks, But during the acute infection, the virus migrates to the regional lumbosacral nerve ganglia and establishes a latent infection. Because of viral latency, HSV infections persist indefinitely, and any decrease in immune function due to stress, trauma, concurrent viral infection, or hormonal changes can trigger reactivation of the virus and recurrence of the skin and mucosal lesions. As expected, recurrences are much more common in immune-suppressed individuals. Morphology. By the time an HSV lesion is biopsied, it typically has ulcerated. The epithelium is desquamated, and marked acute inflammation is present in the ulcer band. Smears of the inflammatory exudate from active lesions show characteristic cytopathic changes consisting of multinucleated squamous cells containing eosinophilic to basophilic viral inclusions with a ground glass appearance. Fig. 22.2. Transmission of HSV takes place mainly during the active phase, but occasionally may occur during the latent phase due to subclinical virus shedding. Condoms and antiviral therapies reduce the risk of transmission, but do not prevent it completely. As with other sexually transmitted diseases, the virus is more readily transmitted to women than to men. Previous infection with HSV-1 seems to reduce susceptibility to HSV-2 infection. The gravest consequence of HSV infection is transmission to the neonate during birth. This risk is highest if the infection is active during delivery, and particularly if it is a primary initial infection in the Figure 22.2 herpes simplex virus HSV infection cervical smear. The cell in the center shows HSV cytopathic effect. Infected cells become multinucleated and contain intranuclear viral inclusions with a characteristic ground glass appearance. Cesarean delivery is warranted in such cases to prevent transmission to the neonate. Another important consequence of active genital HSV infection is that it increases the risk of HIV-1 acquisition and transmission. The diagnosis is based on typical clinical findings and HSV detection. The purulent exudate is aspirated from the lesions and inoculated into a tissue culture. The viral cytopathic effect can be seen after 48 to 72 hours, and the virus can then be serotyped. In addition, some laboratories offer more sensitive polymerase chain reaction tests, enzyme-linked immunosorbent assays, and direct immunofluorescent antibody tests for detection of HSV and lesional secretions. Individuals with primary, acute HSV infection do not have serum anti-HSV antibodies. Detection of anti-HSV antibodies in the serum is indicative of recurrent/latent infection. There is no effective treatment for latent HSV. However, antiviral agents like acyclovir or famciclovir shorten the length of the initial and recurrent symptomatic phases. The ultimate solution is an effective vaccine, a tantalizing goal yet to be realized. Other lower female genital tract infections, as mentioned earlier, a variety of other viruses, fungi, and bacteria can also cause symptomatic infections of the lower genital tract. Those that are most common include the following. Molluscum contagiosum is a cutaneous or mucosal lesion caused by poxvirus. Fig. 22.3. There are 4 types of molluscum contagiosum viruses: MCVS, MCV1 to MCV4, with MCV1 being the most prevalent and MCV2 being most often sexually transmitted. The infections are common in young children between 2 and 12 years of age, in whom they are transmitted through direct contact or shared articles, for example, towels. Molluscum may affect any area of the skin, but is most common on the trunk, arms, and legs. In adults, molluscum infections are typically sexually transmitted and affect the genitals, lower abdomen, buttocks, and inner thighs. The average, 988. Chapter 22. The female genital tract. A B. Figure 22.3. Molluscum contagiosum infection. A low-power appearance of a dome-shaped papule with dimpled center. E. High-power magnification reveals intracytoplasmic viral inclusions. Incubation period is 6 weeks. Diagnosis is based on the characteristic clinical appearance of pearly, dome-shaped papules with a dimpled center. The papules measure 1 to 5 mm in diameter, and their central waxy core contains cells with cytoplasmic viral inclusions. See Fig. 22.3b. Fungal infections, especially those caused by yeast candida, are extremely common. In fact, yeast are part of many women's normal vaginal microflora, and the development of symptomatic candidiasis is typically a result of a disturbance in the patient's vaginal microbial ecosystem. Diabetes mellitus, antibiotics, pregnancy, and conditions that compromise neutrophil or Th17 T cell function increase the risk of symptomatic candidal infection, which manifests itself by marked vulvovaginal pruritus, erythema, swelling, and curd-like vaginal discharge. Severe infection may result in mucosal ulcerations. The diagnosis is made by finding the pseudospores or filamentous fungal hyphae in wet KOH mounts of the discharge or on Pap Nicolai or Pap smear. Even though sexual transmission of yeast infection has been documented, candidiasis is not considered a sexually transmitted disease. Trichomonas vaginalis is a large, flagellated ovoid protozoan that is usually transmitted by sexual contact. Infected patients may be asymptomatic or may complain of yellow, frothy vaginal discharge, vulvovaginal discomfort, dysuria, painful urination, and dyspareunia, painful intercourse. The vaginal and cervical mucosa typically has a fiery red appearance, with marked dilation of cervical mucosal vessels resulting in characteristic colposcopic appearance of strawberry cervix. Bartonella vaginalis is a gram-negative coccobacillus that is implicated as the main cause of bacterial vaginosis vaginitis. Patients typically present with thin, green-gray, malodorous fishy vaginal discharge. Pap smears reveal superficial and intermediate squamous cells covered with a shaggy coat of coccobacilli. Bacterial cultures in such cases reveal G. vaginales, and other bacteria, including anaerobic peptostreptococci and aerobic alpha-hemolytic streptococci. In pregnant patients, bacterial vaginosis has been implicated in premature labor. Uriplasma urolyticum and Mycoplasma hemianus species account for some cases of vaginitis and cervicitis and have been implicated in chorioamnionitis and premature delivery in pregnant patients. Chlamydia trachomatis infections mainly take the form of cervicitis. However, in some patients the infection may ascend to the uterus and fallopian tubes, resulting in endometritis and salpingitis. Thus, chlamydia is one of the causes of pelvic inflammatory disease, as discussed next. Infections involving the lower and upper genital tract. Pelvic inflammatory disease PID. PID is an infection that begins in the vulva or vagina and spreads upward to involve most of the structures in the female genital system, resulting in pelvic pain, adnexal tenderness, fever, and vaginal discharge. Neisseria gonorrhoeae continues to be a common cause of PID, the most serious complication of gonorrhea in women. Chlamydia infection is another well-recognized cause of PID. Infections after spontaneous or induced abortions and normal or abnormal deliveries called puerperal infections are also important causes of PID. In these situations, the infections are typically polymicrobial and may be caused by Staphylococci, Streptococci, coliforms, and Clostridium perfringens. With gonococcus, inflammatory changes start to appear approximately 2 to 7 days after inoculation. The initial infection most commonly involves the endocervical mucosa, but it may also begin in the Bartholin gland and other vestibular or periurethral glands. From these sites, the organisms may spread upward to involve the fallopian tubes and tubovarian region. The non-gonococcal bacterial infections that follow induced abortion, dilation, and curettage of the uterus, and other surgical procedures are thought to spread upward from the uterus through the lymphatics or venas. Vulva 989, a B. Figure 22.4 salpingitis. Acute salpingitis, note the dilated tube lumen and edematous tubal plica expanded by inflammatory cell infiltrates. Pus fills the center of the fallopian tube. B. Chronic salpingitis showing scarring and fusion of the plica with formation of gland-like spaces. Such scarring may cause infertility or ectopic tubal pregnancy. Channels rather than on the mucosal surfaces. Therefore, these infections tend to produce more inflammation within the deeper layers of the organs than gonococcal infections. Morphology. Gonococcal infection is characterized by marked acute inflammation of involved mucosal surfaces. Smears of the inflammatory exudate disclose phagocytose gram-negative diplococcus within neutrophils. However, definitive diagnosis requires culture or detection of gonococcal RNA or DNA. If infection spreads, the endometrium is usually spared for unclear reasons, but within the fallopian tubes, an acute suppurative salpingitis ensues. Fig. 22, 4a. The tubal mucosa becomes congested and diffusely infiltrated by neutrophils, plasma cells, and lymphocytes, resulting in epithelial injury and sloughing of the plica. The tubal lumen fills with purulent exudate that may leak out of the fimbriated end. The infection may then spread to the ovary to create a salpingo-oophoritis. Collections of pus may accumulate within the ovary and tubal ovarian abscess or tubal lumen piles up in C. Fig. 22, 4. With time, the infecting organisms may disappear, but the tubal plica, denuded of epithelium, adhere to one another and slowly fuse in a reparative, scarring process that forms gland-like spaces and blind pouches, referred to as chronic salpingitis. See Fig. 22, 4b. Scarring of the tubal lumen and fimbriae may prevent the uptake and passage of oocytes, leading to infertility or ectopic pregnancy. Hydrosalpinx may also develop as a consequence of the fusion of the fimbriae and the subsequent accumulation of the tubal secretions and tubal distension. As compared to gonococcal infections, PID caused by Staphylococci, Streptococci, and the other puerperal invaders tends to show less involvement of the mucosa and the tube lumen, and more inflammation within the deeper tissue layers. These infections often spread throughout the wall to involve the serosa and the broad ligaments, pelvic structures, and peritoneum. Bacteremia is a more frequent complication of streptococcal or staphylococcal PID than of gonococcal infections. The acute complications of PID include peritonitis and bacteremia, which in turn may result in endocarditis, meningitis, and suppurative arthritis. The chronic sequelae of PID include infertility and tubal obstruction, ectopic pregnancy, pelvic pain, and intestinal obstruction due to adhesions between the bowel and pelvic organs. In the early stages, gonococcal infections are usually readily controlled with antibiotics, although penicillin-resistant strains have emerged. Infections that become walled off in tubal ovarian abscesses are difficult to eradicate with antibiotics, and it sometimes becomes necessary to remove the organ surgically. Post-abortion and postpartum PIDs may also be amenable to treatment with antibiotics, but are far more difficult to control because of the broad spectrum of pathogens that may be involved. Vulva. Diseases of the vulva in the aggregate constitute only a small fraction of gynecologic practice. Many inflammatory diseases that affect skin elsewhere on the body also occur on the vulva, such as psoriasis, eczema, and allergic dermatitis. Because it is constantly exposed to secretions and moisture, the vulva is more prone to superficial infections than skin elsewhere on the body. Non-specific vulvitis is particularly likely to occur in the setting of immunosuppression. Most skin cysts, epidermal inclusion cysts, and skin tumors such as squamous cell carcinoma, basal cell carcinoma, and melanoma can also occur in the vulva. Here we discuss vulvar disorders that are relatively specific in 990 Chapter 22 the female genital tract, B figure 22.5 non-neoplastic epithelial vulvar disorders. Lichen sclerosis. There is marked thinning of the epidermis, sclerosis of the superficial dermis, and chronic inflammatory cells in deeper dermis. B. Squamous cell hyperplasia, displaying thickened epidermis and hyperkeratosis. Common, including Bartholin cyst, non-neoplastic epithelial disorders, benign exophytic lesions, and tumors of the vulva. Bartholin cyst. Infection of the Bartholin gland produces an acute inflammation anitis and may result in an abscess. Bartholin duct cysts are relatively common, occur at all ages, and result from obstruction of the duct by an inflammatory process. These cysts are usually lined by transitional or squamous epithelium. They may become large, up to 3 to 5 cm in diameter, and produce pain and local discomfort. Bartholin duct cysts are either excised or open permanently marsupialization. Non-neoplastic epithelial disorders. Leukoplakia is a descriptive clinical term for opaque, white, plaque-like epithelial thickening that may produce pruritus and scaling. Leukoplakia literally, white plaques may be caused by a variety of benign, premalignant, or malignant disorders, including the following: inflammatory dermatosis, for example, psoriasis, chronic dermatitis, lichen sclerosis, and squamous cell hyperplasia. Neoplasias, such as vulvar intraepithelial neoplasia VIN, Paget disease, and invasive carcinoma. Inflammatory dermatosis associated with leukoplakia are described in Chapter 25, while neoplastic disorders are discussed later in this chapter. Here the major non-neoplastic causes of leukoplakia, lichen sclerosis and squamous cell hyperplasia, are briefly discussed. Lichen sclerosis. Lichen sclerosis presents as smooth, white plaques or macules that in time may enlarge and coalesce, producing a surface that resembles porcelain or parchment. When the entire vulva is affected, the labia become atrophic and agglutinated, and the vaginal orifice constricts. Histologically, the lesion is characterized by marked thinning of the epidermis. Fig. 22. 5. Degeneration of the basal epithelial cells, excessive keratinization, hyperkeratosis, sclerotic changes of the superficial dermis, and a band-like lymphocytic infiltrate in the underlying dermis. The disease occurs in all age groups but is most common in postmenopausal women. It may also be encountered elsewhere on the skin. Its pathogenesis is uncertain, but the presence of activated T cells in the subepithelial inflammatory infiltrate and the increased frequency of autoimmune disorders in affected women suggest that an autoimmune reaction is involved. Although lichen sclerosis is not itself a premalignant lesion, women with symptomatic lichen sclerosis have a slightly increased chance of developing squamous cell carcinoma of the vulva. Squamous cell hyperplasia, previously called hyperplastic dystrophy or lichen simplex chronicus. Squamous cell hyperplasia is a nonspecific condition resulting from rubbing or scratching of the skin to relieve pruritus. Clinically, it presents as leukoplakia, and histologic examination reveals thickening of the epidermis, acanthosis, and hyperkeratosis. See Fig. 22. 5b. Lymphocytic infiltration of the dermis is sometimes present. The hyperplastic epithelium may show mitotic activity but lacks cellular atypia. While squamous cell hyperplasia is not considered premalignant, it is sometimes present at the margins of vulvar cancers. Benign exophytic lesions. Benign raised exophytic or wart-like lesions of the vulva may be caused by infection or may be reactive conditions of unknown etiology. Condyloma acuminatum, a papillomavirus-induced lesion, also called a genital wart, and syphilitic condyloma latum described in Chapter 21 are consequences. Vulva 991, a B figure 22.6 condyloma acuminatum, a low-power view showing exophytic, papillary architecture. B. High-power view reveals human papillomavirus cytopathic effect coilocytic atypia characterized by atypical, enlarged, hyperchromatic nuclei with perinuclear halos arrow. Sexually transmitted infections. Vulvar fibroepithelial polyps, or skin tags, are similar to skin tags occurring elsewhere on the skin. Vulvar squamous papillomas are benign exophytic proliferations covered by non-keratinized squamous epithelium that develop on vulvar surfaces. They may be single or numerous vulvar papillomatosis. The etiology of fibroepithelial polyps and squamous papillomas is unknown. Condyloma acuminatum. Condylomata acuminata are benign genital warts caused by low-risk HPV, mainly type 6 and 11. They may be solitary, but are more frequently multifocal, and they may involve vulvar, perineal, and perianal regions as well as the vagina and, less commonly, the cervix. The lesions are identical to those found on the penis and around the anus in males. Chapter 21. On histologic examination, they consist of papillary, exophytic, tree-like cores or stroma covered by thickened squamous epithelium. Fig. 22. 6a. The surface epithelium shows characteristic viral cytopathic changes referred to as coilocytic atypia. See Fig. 22. 6b. Which manifest as nuclear enlargement, hyperchromation, and a cytoplasmic perinuclear halo. See the cervix section later in this chapter. Condylomata acuminata are not precancerous lesions. HPV vaccines described later provide excellent protection against infection by low-risk HPV and genital warts. Squamous neoplastic lesions. Vulvar intraepithelial neoplasia and vulvar carcinoma. Carcinoma of the vulva is an uncommon malignant neoplasm approximately 1/8 as frequent as cervical cancer, representing about 3% of all genital cancers in the female. Approximately 2/3 occur in women older than 60. Years of age. Squamous cell carcinoma is the most common histologic type of vulvar cancer. In terms of etiology, pathogenesis, and histologic features, vulvar squamous cell carcinomas are divided into two groups. Basiloid and Morty carcinomas are related to infection with high-risk HPVs, most commonly HPV-16. These are less common 30% of cases and occur in younger women average 60 years of age. Keratinizing squamous cell carcinomas are unrelated to HPV infection. These are more common 70% of cases and occur in older women average 75 years of age. Basiloid and Morty carcinomas develop from an in situ precursor lesion called classic vulvar intraepithelial neoplasia VIN. This form of VIN occurs mainly in reproductive age women and includes lesions formerly designated as carcinoma in situ or bone disease. The risk factors for VIN are the same as those associated with cervical squamous intraepithelial lesions, for example, young age at first intercourse, multiple sexual partners, male partner with multiple sexual partners, as both are related to HPV infection. VIN is frequently multicentric, and 10% to 30% of patients with VIN also have vaginal or cervical HPV-related lesions. Spontaneous regression of classic VIN has been reported, usually in younger women. The risk of progression to invasive carcinoma is higher in women who are older than 45 years of age or who are immunosuppressed. Keratinizing squamous cell carcinoma occurs most often in individuals with long-standing lichen sclerosis or squamous cell hyperplasia and is not related to HPV. It arises from a precursor lesion referred to as differentiated vulvar intraepithelial neoplasia differentiated VIN. It is postulated that chronic epithelial irritation and lichen sclerosis or squamous cell hyperplasia may contribute to a gradual evolution to the malignant phenotype, presumably through acquisition of driver mutations in oncogenes and tumor suppressor genes. In line with this idea, some investigators have reported a high frequency of T53 mutations in differentiated VIN. Chapter 22, the female genital tract. B. Figure 22.7 Human papillomavirus HPV-related vulvar pre-neoplastic and malignant lesions. A classic vulvar intraepithelial neoplasia HPV positive, showing small, immature basiloid cells encompassing full thickness of the epithelium. No invasion is present. B. Basiloid vulvar carcinoma HPV positive, composed of invasive small, immature basiloid cells. There is a focus of necrosis red area. Morphology: tightly packed cells that lack maturation and resemble the basal layer of the normal epithelium. The tumor may have foci of central necrosis. By contrast, warty carcinoma is characterized by exophytic, papillary architecture and prominent coilocytic atypia. Differentiated VIN is characterized by marked atypia of the basal layer of the squamous epithelium and normal appearing differentiation of the more superficial layers. Fig. 22.8a. Invasive keratinizing squamous cell carcinomas that arise in differentiated VIN contain nests and tons of malignant squamous epithelium with prominent central keratin pearls. See Fig. 22.8b. 992. The lesions of classic VIN may be discrete and white hyperkeratotic or slightly raised and pigmented. Microscopically, it is characterized by epidermal thickening, nuclear atypia, increased mitosis, and lack of cellular maturation. Fig. 22.7 features analogous to those seen in cervical squamous intraepithelial lesions. SIL. See the cervix section later in this chapter. Invasive carcinomas that arise from classic VIN may be exophytic or indurated with central ulceration. On histologic examination, basiloid carcinoma. See Fig. 22.7b consists of nests and cords of small. B. Figure 22.89 Human papillomavirus HPV vulvar pre-neoplastic and malignant lesions. A differentiated vulvar intraepithelial neoplasia HPV negative, showing maturation of the superficial layers, hyperkeratosis, and atypia of basal epithelial cells. No invasion is present. B. Well differentiated, keratinizing squamous cell carcinoma of the vulva HPV negative composed of invasive tumor nests with central keratin pearls. 993. The risk of cancer development in VIN depends on duration and extent of disease, and the immune status of the patient. Invasive carcinomas associated with lichen sclerosis, squamous cell hyperplasia, and differentiated VIN may develop in an insidious fashion and may be misinterpreted as dermatitis or leukoplakia for long periods. Once invasive cancer develops, the risk of metastatic spread is determined by the size of tumor, the depth of invasion, and whether there is lymphatic invasion. The initial spread is to inguinal, pelvic, iliac, and periaortic lymph nodes. Ultimately, hematogenous dissemination to the lungs, liver, and other internal organs may occur. Patients with lesions less than 2 cm in diameter have a 90% 5-year survival rate after treatment with vulvectomy and lymphadenectomy. However, larger lesions with lymph node involvement have a poor prognosis. Glandular neoplastic lesions. Like the breast, the vulva contains modified apocrine sweat glands. Presumably because of these breast-like features, the vulva may be involved by two tumors with counterparts in the breast, papillary hidradenomas and extramammary Paget disease. Papillary hidradenomas. Papillary hidradenomas presents as a sharply circumscribed nodule, most commonly on the labia majora or interlabial folds, and may be confused clinically with carcinoma because of its tendency to ulcerate. Its histologic appearance is identical to that of intraductal papilloma of the breast and consists of papillary projections covered by two cell layers, an upper layer of columnar secretory cells and a deeper layer of flattened myoepithelial cells. These myoepithelial elements are characteristic of sweat glands and sweat gland tumors. Fig. 22.9. Extramammary Paget disease. This curious and rare lesion of the vulva is similar in its manifestations to Paget disease of the breast. Chapter 23. In the vulva, it presents as a poritic, red, crusted, map-like area, usually on the labia majora. Figure 22.9. Papillary hydrodenoma of the vulva. A well-circumscribed tumor composed of benign papillary projections covered with columnar secretory epithelium and underlying myoepithelial cells. In contrast to Paget disease of the nipple, in which 100% of patients have an underlying ductal breast carcinoma, vulvar Paget is typically not associated with underlying cancer and is confined to the vulvar epidermis. Treatment consists of wide local excision, which is necessary because Paget cells spread laterally within the epidermis and may be present beyond the confines of the grossly visible lesion. Intraepidermal Paget disease may persist for many years or even decades without invasion or metastasis. In the rare instances when invasion develops, the prognosis is poor. Morphology. Paget disease is a distinctive intraepithelial proliferation of malignant cells. Paget cells are larger than surrounding keratinocytes and are seen singly or in small clusters within the epidermis. Fig. 22.10a. The cells have pale cytoplasm containing mucopolysaccharide that stains with periodic acid, Skif PAS, Alcian blue, or mucocarmine stains. In addition, unlike squamous epithelium, the cells express cytocratin 7C. Fig. 22.10b. Ultrastructurally, Paget cells display apocrine, ecrine, and keratinocyte differentiation and presumably arise from multipotent cells found within the mammary gland, like ducts of the vulvar skin. Vulva. Key concepts. Approximately 30% of vulvar cancers are caused by infection with high-risk HPVs, principally HPV-16. These cancers develop from an in situ lesion termed classic vulvar intraepithelial neoplasia, classic VIN. Most vulvar cancers, 70%, are not related to HPV and develop in a background of lichen sclerosis or squamous cell hyperplasia from the premalignant lesion called differentiated vulvar intraepithelial neoplasia, differentiated VIN. Chapter 22. The female genital tract. A B. Figure 22.10. Paget disease of the vulva. The epidermis is infiltrated by large cells with pale pink cytoplasm that are spreading along the basal portion of the squamous epithelium. There is inflammation in the underlying dermis. B. Immunostaining for cytocratin 7 highlights the intraepidermal Paget. For example, in the adult, inflammation that begins in the vulva and perivulvar structures often spreads to the cervix without significant involvement of the vagina. Primary lesions of the vagina are rare, the most serious being vaginal squamous cell carcinoma. They are discussed only briefly here. Developmental anomalies. Septate, or double, vagina is an uncommon anomaly that arises from a failure of Mullerian duct fusion and is accompanied by a double uterus diaphyse. These and other anomalies of the external genitalia may be the manifestations of genetic syndromes. In utero exposure to diethylstilbestrol DES, used to prevent threatened abortions in the 1942 to 1960s, or other unknown factors that perturb reciprocal epithelial stromal signaling during fetal development. During embryonal development, the vagina is initially covered by columnar, endocervical type epithelium. This is normally replaced by squamous epithelium advancing upward from the urogenital sinus. Small patches of residual glandular epithelium may persist into adult life. Such areas are recognized as vaginal adenosis, which on examination presents as red, granular areas that stand out from the surrounding normal pale pink vaginal mucosa. Microscopically, adenosis consists of columnar mucinous epithelium indistinguishable from endocervix. Adenosis is found in only a small percentage of adult women, but has been reported in 35% to 90% of women exposed to DS in utero. Rare cases of clear cell carcinoma arising in DS-related adenosis were recorded in teenagers and young adult women in the 1970 seconds and 1980 seconds, resulting in discontinuation of DS treatment. Gardner duct cysts are relatively common lesions found along the lateral walls of the vagina that are derived from Wolffian mesomphric duct breasts. They consist of 1 to 2 cm. Fluid-filled submucosal cysts. Other cysts, including mucus cysts, which occur in the proximal vagina, are derived from Mullerian epithelium. Another Mullerian-derived lesion, endometriosis described later, may occur in the vagina and clinically simulate a neoplasm. Malignant and malignant neoplasms of the vagina. Most benign tumors of the vagina occur in reproductive age women and include stromal tumors, stromal polyps, lamiomas, and hemangiomas. The most common malignant tumor to involve the vagina is carcinoma spreading from the cervix, followed by primary squamous cell carcinoma of the vagina. Infants may develop a unique, rare malignancy, embryonal rhabdomyosarcoma, sarcoma botryoides, vaginal intraepithelial neoplasia, and squamous cell carcinoma. Virtually all primary carcinomas of the vagina are squamous cell carcinomas associated with high-risk HPV infection. Vaginal carcinoma is extremely uncommon, about 0.6 per 100,000 women yearly, and accounts for about 1% of malignant neoplasms in the female genital tract. The greatest risk factor is a previous carcinoma of the cervix or vulva. 1% to 2% of women with an invasive cervical carcinoma eventually develop a vaginal squamous cell carcinoma. Squamous cell carcinoma of the vagina arises from a premalignant lesion, vaginal intraepithelial neoplasia, analogous to cervical squamous intraepithelial lesion SIL. See the cervix section later in this chapter. Most often the invasive tumor affects the upper vagina, particularly the posterior wall at the junction with the ectocervix. The lesions in the lower two-thirds of the vagina metastasize to the inguinal nodes, whereas lesions in the upper vagina tend to spread to regional iliac nodes. Cervix 995, embryonal rhabdomyosarcoma, also called sarcoma botryoides. This uncommon vaginal tumor composed of malignant embryonal rhabdomyoblasts is most frequently found in infants and children younger than 5 years of age. These tumors tend to grow as polypoid, rounded, bulky masses that have the appearance and consistency of grape-like clusters, hence the designation botryoids, or grape-like fig. 22.11. The tumor cells are small and have oval nuclei, with small protrusions of cytoplasm from one end, resembling a tennis racket. Rarely, striations indicative of muscle differentiation can be seen within the cytoplasm. Beneath the vaginal epithelium, the tumor cells are crowded in a so-called cambium layer, but in the deep regions they lie within a loose edematous fibromyxomatous stroma that may contain many inflammatory cells. Such lesions can be mistaken for benign inflammatory polyps. The tumors tend to invade locally and cause death by penetration into the peritoneal cavity or by obstruction of the urinary tract. Conservative surgery coupled with chemotherapy offer the best hope, particularly in cases diagnosed sufficiently early. Figure 22.11 Sarcoma botryoides, embryonal rhabdomyosarcoma of the vagina appearing as a polypoid mass protruding from the vagina. Courtesy Dr. Michael Donovan, Children's Hospital, Boston, Mass. Cervix. Anatomically, the cervix consists of the external vaginal portio ectocervix and the endocervical canal. The ectocervix is visible on vaginal examination and is covered by a mature squamous epithelium that is continuous with the vaginal wall. The squamous epithelium converges centrally at a small opening termed the external os that leads to the endocervical canal. The endocervix is lined by columnar, mucus-secreting epithelium. The point where the squamous and the columnar epithelium meet is referred to as the squamocolumnar junction. Fig. 22.12. Position of the mature squamous cells. Junction is variable and changes with age and hormonal influence, but in general the junction moves upward into the endocervical canal with time. The replacement of the glandular epithelium by advancing squamous epithelium is a process called squamous metaplasia. The area of the cervix where the columnar epithelium coexists with the squamous epithelium is termed the transformation zone. The unique epithelial environment of the cervix renders it highly susceptible to infection with HPV, the main cause of cervical cancer. Immature squamous cells in the transformation zone are most susceptible to HPV infection, and as a result this is where the majority of cervical precursor lesions and cervical cancers develop. Inflammations, immature squamous cells, squamocolumnar junction, columnar glandular cells. Figure 22.12 cervical squamocolumnar junction showing a transition from mature, licogenized squamous epithelium to columnar endocervical glandular epithelium. Superficial, mature squamous epithelial cells are not susceptible to human papillomavirus HPV infection. The HPV susceptible cells include immature basal squamous cells and endocervical glandular cells. Acute and chronic cervicitis at the onset of menarche. The production of estrogens by the ovary stimulates maturation of the cervical and vaginal squamous mucosa and formation of intracellular glycogen vacuoles in the squamous cells. As these cells are shed, the glycogen provides a substrate for various endogenous vaginal aerobes and anaerobes, but particularly lactobacilli, which are the dominant microbial species in the normal vagina. Lactobacilli produce lactic acid, which maintains the vaginal pH below 4.5, suppressing the growth of other saprophytic and pathogenic organisms. In addition, at low pH, lactobacilli produce bacteriotoxic hydrogen peroxide HORO. If the pH becomes alkaline due to bleeding, sexual intercourse, or vaginal douching, HORO production by lactobacilli decreases. Antibiotic therapy that suppresses lactobacilli can also cause the pH to rise. In each of these settings, the altered vaginal environment promotes the overgrowth. 996 Chapter 22 The female genital tract. Figure 22.13 Endocervical polyp composed of a dense fibrous stroma covered with endocervical columnar epithelium. Of other microorganisms, which may result in cervicitis or vaginitis. Some degree of cervical inflammation may be found in virtually all women, and it is usually of little clinical consequence. However, infections by gonococci, chlamydia, mycoplasmas, and HSV may produce significant acute or chronic cervicitis and are important to identify due to their association with upper genital tract disease, complications during pregnancy, and sexual transmission. Marked cervical inflammation produces reparative and reactive changes of the epithelium and shedding of atypical appearing squamous cells, and therefore may cause an abnormal Pap test result. Endocervical polyps. Endocervical polyps are common benign exophytic growths that arise within the endocervical canal. They vary from small, sessile bumps to large polypoid masses that may protrude through the cervical os. Histologically, they are composed of a fibrous stroma covered by mucus-secreting endocervical glands, often accompanied by inflammation. Fig. 22.13. Their main significance is that they may be the source of irregular vaginal spotting or bleeding that arouses suspicion of some more ominous lesion. Simple curettage or surgical excision is curative for malignant and malignant neoplasms of the cervix. Worldwide, cervical carcinoma is the fourth most common cancer in women, with an estimated 570,000 new cases in 2018, of which more than one half will prove fatal. In the United States, It was estimated in 2019 that 13,179 women would be diagnosed with cervical cancer and that 4,250 women would die of the disease. 50 years ago, carcinoma of the cervix was the leading cause of cancer death in women in the United States, but the death rate has declined by 75% to its present rank as the 13th cause of cancer mortality. No form of cancer better documents the remarkable benefits of effective screening, early diagnosis, and curative therapy than does cancer of the cervix. Most credit for these dramatic gains belongs to the effectiveness of the Pap test in detecting cervical precursor lesions, some of which would have progressed to cancer if not treated. In addition, the Pap test can also detect low-stage, highly curable cancers. The accessibility of the cervix to Pap testing and visual examination colposcopy, as well as the slow progression from precursor lesions to invasive carcinoma typically over the course of decades, provides ample time for screening, detection, and preventive treatment. Pathogenesis. High-risk HPVs are by far the most important factor in the development of cervical cancer. HPVs are DNA viruses that are grouped into those of high and low oncogenic risk based on their genotypes. There are 15 high-risk HPVs that are currently identified, but HPV 16 alone accounts for almost 60% of cervical cancer cases, and HPV 18 accounts for another 10% of cases. Other HPV types contribute to less than 5% of cases, individually. High-risk HPVs are also implicated in squamous cell carcinomas arising at many other sites, including the vagina, vulva, penis, anus, tonsil, and other oropharyngeal locations. As noted earlier, low oncogenic risk HPVs are the cause of sexually transmitted vulvar, perineal, and perianal warts kinoloma ecumeni. Genital HPV infections are extremely common. Most of them are asymptomatic, do not cause any tissue changes, and therefore are not detected on Pap tests. The prevalence of HPV in cervical smears in women with normal Pap test results peaks between 20 and 24 years of age, around the onset of sexual activity, and subsequently declines as protective immunity is established and women enter into monogamous relationships. Most HPV infections are transient. Overall, 50% of HPV infections are cleared within 8 months, and 90% of infections are cleared within 2 years. The duration of the infection is related to HPV type, as infections with high-risk HPVs take longer to clear on average than infections with low-risk HPVs, 13 months versus 8 months, respectively. Persistent infection increases the risk of the development of cervical precursor lesions and subsequent carcinoma. Productive, persistent HPV infection requires viral entry into immature basal epithelial cells. As a result, surface is covered with mature, intact squamous epithelium, such as the ectocervix, vagina, vulva, penis, and oropharynx, are normally resistant to HPV infection. Sites in the female genital tract that are susceptible to infection include areas of squamous epithelial trauma and repair, where the virus may access basal cells, and the immature metaplastic squamous cells that are present at the squamous-columnar junction of the cervix. See Fig. 22.12. The cervix, with its relatively large areas of immature squamous metaplastic epithelium, is particularly vulnerable to HPV infection. Other sites in the body that are vulnerable to HPV infection include the squamous-columnar junction of the anus and the squamous cells of oropharyngeal tonsillar crypts, both relatively common sites of HPV-associated cancers in individuals who practice anal or oral sex, respectively. The ability of HPV to act as a carcinogen depends on the viral S6 and S7 proteins, which interfere with activity of the key tumor suppressor proteins, 53 and RB, respectively. Although HPV infects immature squamous cells, viral replication occurs in maturing squamous cells. Normally, these more mature cells are arrested in the gone phase of the cell cycle, but they continue to actively progress through the cell cycle when infected with HPV, which uses Cervix 997, the whole cell DNA synthesis machinery to replicate its own genome. As you will recall from Chapter 7, viral S7 protein binds the hypophosphorylated active form of RB and promotes its degradation via the proteasome pathway, and also binds and inhibits P21 and P27, two important cyclin-dependent kinase inhibitors. Removal of these controls not only enhances cell cycle progression, but also impairs the ability of cells to repair DNA damage. The DNA repair defect in infected cells is exacerbated by S6 proteins encoded by high-risk HPV subtypes, which bind 53 and promote its degradation by the proteasome. In addition, S6 upregulates the expression of telomerase, which leads to cellular immortalization. The net effect is increased proliferation of cells that are prone to acquire additional mutations that may lead to cancer development. By contrast to high-risk HPVs, the S7 proteins of low-risk HPVs bind RB with lower affinity, while the S6 proteins of low-risk HPVs fail to bind 53 altogether and instead appear to dysregulate growth and survival by interfering with the Notch signaling pathway. Another factor that contributes to malignant transformation by HPV is the physical state of the virus. The viral DNA is integrated into the host cell genome in most cancers. This configuration increases the expression of S6 and S7 genes, and may also dysregulate oncogenes near the sites of viral insertion, such as MYC. By contrast, viral DNA is extrachromosomal episomal in precursor lesions associated with high-risk HPVs and in condylomata associated with low-risk HPVs. Even though HPV is firmly established as the major cause of cervical cancer, It is worth remembering that although a high percentage of young women are infected with one or more HPV types during their reproductive years, only a few develop cancer. Thus, other factors, such as exposure to co-carcinogens and host immune status, influence whether an HPV infection regresses or persists and eventually leads to cancer. Cervical intraepithelial neoplasia, squamous intraepithelial lesions. The classification of cervical precursor lesions has evolved over time, and the terms from the various classification systems are used interchangeably. Hence, a brief review of the terminology is warranted. The oldest classification system grouped lesions as having mild dysplasia on one end and severe dysplasia/carcinoma in situ on the other. This was followed by the cervical intraepithelial neoplasia CIN classification, with mild dysplasia termed CINI, moderate dysplasia termed CIN Roman II, and severe dysplasia termed CIN Roman III. Because the decision with regard to patient management is two-tiered observation versus surgical treatment, the three-tier classification system has been recently simplified to a two-tiered system, with CINI renamed low-grade squamous intraepithelial lesion LSIL and CIN Roman II and CIN Roman III combined into one category referred to as high-grade squamous intraepithelial lesion HL Table 22.1. LSIL does not progress directly to invasive carcinoma, and, in fact, most cases regress spontaneously. Only a small percentage progress to HL. LSIL represents a productive HPV infection in which there is a high level of viral. 22. One's classification system precursor. Arlesio NSF table. Dysplasia/carcinoma in situ CIN. Mild dysplasia CINI. Moderate dysplasia CIN Roman II. Severe dysplasia CIN Roman III. Carcinoma in situ CIN Roman III. SIN. Cervical intraepithelial neoplasia. SIL. Squamous intraepithelial lesion. Or squamous cervical. SIL. Current classification. Low-grade SIL LSIL. High-grade SIL HL. High-grade SIL HL. High-grade SIL HL. Replication, but only mild alterations in the growth of host cells. For these reasons, LSIL is not treated like a premalignant lesion. LSIL is approximately 10 times more common than HL. By contrast to LSIL, HL is considered to be at high risk for progression to carcinoma. In HL, there is a progressive deregulation of the cell cycle by HPV, which results in increased cellular proliferation, decreased or arrested epithelial maturation, and a lower rate of viral replication as compared with LSIL. Arrangement of the cell cycle in HL may become irreversible and lead to a fully transformed malignant phenotype. Morphology. The diagnosis of SIL is based on identification of nuclear atypia characterized by nuclear enlargement, hyperchromasia, dark staining, coarse chromatin granules, and variation in nuclear size and shape. Fig. 22.14. Nuclear changes are often accompanied by cytoplasmic halos. At an ultrastructural level, these halos consist of perinuclear vacuoles, a cytopathic change created in part by an HPV-encoded protein that localizes to the membranes of the endoplasmic reticulum. Nuclear alterations associated with perinuclear halos are termed corticocytic atypia. The grading of SIL into low or high grade is based on expansion of the immature cell layer from its normal basal location. If the immature squamous cells are confined to the lower one-third of the epithelium, the lesion is called LSIL. If they expand to the upper two-thirds of the epithelial thickness, it is called HL. The histologic features of LSIL correlate with HPV replication and changes in host cell growth and gene expression. Fig. 22.15. The highest viral loads assessed by in situ hybridization for HPV DNA, see Fig. 22.15b, are found in maturing keratinocytes in the upper half of the epithelium. HPV S6 and S7 proteins prevent cell cycle arrest. As a result, cells in the upper portion of the epithelium express markers of actively dividing cells, such as Ki67c Fig. 22.15c, that are normally confined to the basal layer of the epithelium. Disturbed growth regulation also leads to overexpression of 16, a cyclin-dependent kinase inhibitor. See Fig. 22.15d. Both Ki67 and 16 staining are highly correlated with HPV infection and are useful for confirmation of the diagnosis in equivocal cases of SIL. More than 80% of LSIL and 100% of HL are associated with high-risk HPVs, with HPV 16 being the most. 998 Chapter 22. The female genital tract. Normal sin Roman II, sin Roman III. Figure 22.14. Spectrum of cervical intraepithelial neoplasia. Normal squamous epithelium for comparison. Low grade squamous intraepithelial lesion, cervical intraepithelial neoplasia CINI with corticocytic atypia. High grade squamous intraepithelial lesion HL CIN Roman II with progressive atypia and expansion of the immature basal cells above the lower third of the epithelial thickness. HL CIN Roman III with diffuse atypia, loss of maturation, and expansion of the immature basal cells to the epithelial surface. Common HPV type in both lesions. Table 22.2 shows rates of regression and progression of cells within a two-year follow-up. Although the majority of HLs develop from LSILs, approximately 20% of cases of HL develop novo, independent of any pre-existing LSIL. The rates of progression are by no means uniform, and although HPV type, especially HPV 16, is associated with increased risk, it is difficult to predict the outcome in an individual patient. These findings underscore that the risk of precursor lesions and cancer is conferred only in part by HPV type progression to invasive carcinoma, when it occurs, on average takes place over several decades. Cervical carcinoma. The average age of patients with invasive cervical carcinoma is between 45 and 50 years. Squamous cell carcinoma is the most common histologic subtype, accounting for approximately 80% of cases. The second most common tumor type is adenocarcinoma, which constitutes about 15% of cervical cancer cases and develops from a precursor lesion called adenocarcinoma in situ. Adenosquamous and neuroendocrine carcinomas are rare cervical tumors that account for the remaining 5% of cases. All of the aforementioned tumor types are caused by high-risk HPVs. The progression time. Figure 22.15. A low-grade squamous intraepithelial lesion, routine hematoxylin and eastern staining shows coilocytic change, seen as nuclear enlargement and perinuclear halos. The in situ hybridization test for human papillomavirus deoxyribonucleic acid HPV DNA. Dark granular staining denotes HPV DNA, which is most abundant in the superficial coilocytes. C. Diffuse positivity for the proliferation marker Ki67, seen as brown nuclear staining, illustrates expansion of the proliferating cells from the normal basal location to the superficial layers of the epithelium. E. Up. Regulation of the cyclin-dependent kinase inhibitor 16, seen here as brown staining, characterizes high-risk HPV infections. Cervix 999. Natural histile 2 TF lesions with approximate 2-year follow-up. Lesion regress, persist, progress. LCIL 60%, 30%, 10% to HCIL. HCIL 30%, 60%, 10% to carcinoma. HCIL, high-grade squamous intraepithelial lesion. LCIL, low-grade squamous intraepithelial lesion. A progression within 2 to 10 years. Squamous intraepi. The libidinal. From in situ to invasive adenosquamous and neuroendocrine carcinomas is shorter than in squamous cell carcinoma, and patients with these tumors often present with advanced disease and have a less favorable prognosis. Morphology. Invasive cervical carcinoma may manifest as fungating exophytic or infiltrative masses. Squamous cell carcinoma is composed of nests and tons of malignant squamous epithelium, either keratinizing or non-keratinizing, which invade the underlying cervical stroma. Fig. 22. 16a. B. Adenocarcinoma is characterized by proliferation of glandular epithelium composed of malignant endocervical cells with large, hyperchromatic nuclei and relatively mucin-depleted cytoplasm, resulting in a dark appearance of the glands, as compared with the normal endocervical epithelium. 8b. Figure 22.17. Adenocarcinoma of the cervix. Adenocarcinoma in situ, arrows showing dark glands with atypical, enlarged nuclei adjacent to a normal, pale endocervical gland. Invasive adenocarcinoma. 8b. Figure 22.16. Squamous cell carcinoma of the cervix. Early invasion in squamous cell carcinoma showing an invasive nest breaking through the basement membrane of a high-grade squamous intraepithelial lesion. Invasive squamous cell carcinoma. Fig. 22. 17a. B. Adenosquamous carcinoma is composed of intermixed malignant glandular and squamous epithelium. Neuroendocrine cervical carcinoma has an appearance similar to small cell carcinoma of the lung, chapter 15, but differs in being positive for high-risk HPVs. Advanced cervical carcinoma spreads by direct extension to contiguous tissues, including paracervical soft tissue, urinary bladder, ureters, resulting in hydronephrosis, rectum, and vagina. Lymphovascular invasion results in local and distant lymph nodes metastasis. Distant metastasis may also be found in the liver, lungs, bone marrow, and other organs. Cervical cancer is staged as follows. Stage 0, carcinoma in situ, CIN Roman 3. HCIL. Stage I, carcinoma confined to the cervix. IN, preclinical carcinoma, that is, diagnosed only by microscopy. IN, stromal invasion no deeper than 3 mm and no wider than 7 mm, so-called superficially invasive squamous cell carcinoma. IATWO, maximum depth of invasion of stroma deeper than 3 mm and no deeper than 5 mm taken from base of epithelium. Horizontal invasion no more than 7 mm. Chapter 22. The female genital tract. Histologically invasive carcinoma confined to the cervix, and greater than stage IATWO. Stage Roman 2, carcinoma extends beyond the cervix but not to the pelvic wall. Carcinoma involves the vagina but not the lower third. Stage Roman 3, carcinoma has extended to the pelvic wall. On rectal examination, there is no cancer-free space between the tumor and the pelvic wall. The tumor involves the lower third of the vagina. Stage Roman 4, carcinoma has extended beyond the true pelvis or has involved the mucosa of the bladder or rectum. This stage also includes cancers with metastatic dissemination. Clinical features: more than 1/2 of invasive cervical cancers are detected in women who did not participate in regular screening. While superficially invasive squamous cell carcinomas may be treated by cervical cone excision alone, most invasive cancers are managed by hysterectomy with lymph node dissection and, for advanced lesions, radiation and chemotherapy. The prognosis for invasive carcinomas depends on the stage of the cancer at diagnosis and to some degree on histologic subtype, with small cell neuroendocrine tumors having a very poor prognosis. With current treatments, the 5-year survival rate is 100% for superficially invasive squamous cell carcinomas and less than 20% for tumors extending beyond the pelvis. Most patients with advanced cervical cancer die of the consequences of local tumor invasion, for example, ureteral obstruction, pyelonephritis, and uremia rather than distant metastasis. Cervical cancer screening and prevention. As is well known, cytologic cancer screening has significantly reduced mortality from cervical cancer. In countries where such screening is not widely practiced, cervical cancer continues to exact a high toll. The reason that cytologic screening is so effective in preventing cervical cancer is that most cancers arise from precursor lesions over the course of years. These lesions shed abnormal cells that can be detected on cytologic examination using a spatula or brush. The transformation zone of the cervix is circumferentially scraped and the cells are smeared or spun down onto a slide. Following fixation and staining with the Papnick layer method, the smears are screened microscopically by eye or increasingly with automated image analysis systems. The cellular changes seen on the Pap test, illustrating the spectrum from L cell to H cell, are shown in Fig. 22.18, a B. CD Figure 22.18, the cytology of cervical intraepithelial neoplasia as seen on the Papnick layer smear. The cytoplasmic staining of desquamated cells may be either red or blue. A normal exfoliated superficial squamous cells. B. Low-grade squamous intraepithelial lesion, coilocytes. C. High-grade squamous intraepithelial lesion, H cell. Cervical intraepithelial neoplasia, CI in Roman 2. D. H cells in Roman 3. Note the reduction in cytoplasm and the increase in the nucleus to cytoplasm ratio, which occurs as the grade of the lesion increases. This reflects the progressive loss of cellular differentiation on the surface of the lesions from which these cells are exfoliated. Courtesy Dr. Edmund S. Siebers, Brigham and Women's Hospital, Boston, Mass. 1000. Of uterus and endometrium. 1001. Testing for the presence of HPV DNA in the cervical scrape is a molecular method of cervical cancer screening. HPV testing has a higher sensitivity but lower specificity as compared to the Pap test. HPV DNA testing may be added to cervical cytology for screening in women 30 years of age or older. HPV testing of women younger than 30 years of age is not recommended because of the high incidence of infection, and thus the particularly low specificity of HPV test results in this age group. Cervical cancer screening and preventive measures are carried out in a stepwise fashion. Recommendations for the frequency of Pap screening vary, but in general the first smear should be at 21 years of age or within 3 years of onset of sexual activity, and thereafter every 3 years. After 30 years of age, women who have had normal cytology results and are negative for HPV may be screened every 5 years. Women who have a normal cytology result but test positive for high-risk HPV DNA should have cervical cytology repeated every 6 to 12 months. When the result of a Pap test is abnormal, a colposcopic examination of the cervix and vagina is performed to identify the lesion. The mucosa is examined with a magnifying glass following application of acetic acid, which highlights abnormal epithelium as white spots instead of white areas. Normal appearing areas are biopsied. Women with biopsy-confirmed L cell can be followed in a conservative fashion. Some gynecologists will perform local ablation, for example, cryotherapy of L cell, particularly if there is concern about the reliability of patient follow-up. HL is treated with cervical conization superficial excision. An additional important aspect of cervical cancer prevention is vaccination against high-risk oncogenic HPV, which is now recommended for all girls and boys by 11 to 12 years of age, as well as young men and women up to 26 years of age. 2 HPV vaccines are now FDA licensed. Both provide nearly complete protection against high-risk oncogenic HPV types 16 and 18 together, accounting for approximately 70% of cervical cancers. And one also provides protection against additional 5 high oncogenic risk HPVs as well as 2 low oncogenic risk HPV types 6 and 11, which are responsible for genital warts. Vaccination is now recommended for boys as well as girls due to the role that males play in the spread of HPV to women and the toll that HPV-related anal and oropharyngeal cancers take in men. Vaccines offer protection for up to 10 years. Longer follow-up studies are still pending. Because the HPV vaccines do not protect against all high-risk HPV types, current guidelines recommend that cervical cancer screening be continued as in the past. Key concepts. Cervical L cell is a productive HPV infection that usually regresses spontaneously but occasionally progresses to H cell. H cell is characterized by progressive deregulation of the cell cycle and increasing cellular atypia. H cell may progress to invasive carcinoma. Almost all cervical precursor lesions and cervical carcinomas are caused by high-risk HPV types, most commonly HPV 16. Body of uterus and endometrium. The uterus has 2 major components, the myometrium and the endometrium. The myometrium is composed of tightly interwoven bundles of smooth muscle that form the wall of the uterus. The internal cavity of the uterus is lined by the endometrium, which is composed of glands embedded in a cellular stroma. The uterus is affected by a variety of disorders, the most common of which results from endocrine imbalances, complications of pregnancy, and neoplastic proliferation. Endometrial histology in the menstrual cycle. The endometrium undergoes dynamic physiologic and morphologic changes during the menstrual cycle in response to sex steroid hormones coordinately produced in the ovary. The ovary is influenced by hormones produced by the pituitary gland due to signals from the hypothalamus. Together, hypothalamic, pituitary, and ovarian factors and their interactions regulate maturation of ovarian follicles, ovulation, and menstruation. The histologic appearance of the endometrium may be used to assess hormonal status, document ovulation, and determine causes of endometrial bleeding and infertility. 22.19. Progression through a normal menstrual cycle is correlated with the following histologic features. The cycle commences with menses, during which the superficial portion of the endometrium, referred to as the functionalis, is shed. The proliferative phase is marked by rapid growth of glands and stroma arising from the deeper portion of the endometrium bassalis. During the proliferative phase, the glands are straight, tubular structures lined by regular, tall, pseudostratified columnar cells. Mitotic figures are numerous, and there is no evidence of mucus secretion or vacuolation. The endometrial stroma is composed of spindle cells with scant cytoplasm that are also actively proliferating. See Fig. 22, 19a. Ovulation. Endometrial proliferation ceases and differentiation commences in response to the effects of progesterone made by the corpus luteum in the ovary. Ovulation is initially marked by the appearance of secretory vacuoles beneath the nuclei in the glandular epithelium. See Fig. 22, 19b. Secretory activity is most prominent during the third week of the menstrual cycle, when the basal vacuoles progressively move to the apical surface. By the fourth week, the glands are tortuous, producing a serrated appearance. This serrated or sawtooth appearance is accentuated by secretory exhaustion and shrinkage of the glands. Stromal changes in the late secretory phase, due predominantly to progesterone, are the most significant features. Prominent spiral arterioles appear accompanied by an. Chapter 22. The female genital tract. B. CD Figure 22.19. Histology of the menstrual cycle. A proliferative phase with mitosis arrow. B. Early secretory phase with subnuclear vacuoles arrow. C. Late secretory exhaustion and predecidual changes arrow. D. Menstrual endometrium with stromal breakdown arrow. See text 1002. Increase in ground substance and edema between the stromal cells followed by stromal cell hypertrophy, increased cytoplasmic eosinophilia, predecidual change, and a resurgence of stromal mitosis. See Fig. 22, 19c. Predecidual changes spread throughout the functionalis and are accompanied by a sparse infiltrate of neutrophils and lymphocytes, which in this context are considered normal. The dissolution of the corpus luteum and the subsequent drop in progesterone levels, the functionalis degenerates and bleeding into the stroma occurs, followed by stromal breakdown and onset of the next menstrual cycle. See Fig. 22, 19d. The action of the ovarian hormones on the endometrium primarily occurs through their cognate nuclear receptors. During the proliferative phase, estrogen drives the proliferation of both glands and stroma, sometimes by promoting crosstalk between these two cell types. For example, much of the effect of estrogen on glandular proliferation occurs via stromal cells, which in response to estrogen produce growth factors, for example, insulin-like growth factor 1 and epidermal growth factor that bind receptors expressed on the epithelial cells. During the secretory phase, progesterone downregulates the expression of estrogen receptor in both the glands and the stroma, and as a result, endometrial proliferation is suppressed. Progesterone also promotes the differentiation of the glands and causes functional changes in the stromal cells. Endometrial stem cells have been identified that likely have a central role in the regeneration of the endometrium after menses. They may also contribute to the development of ectopic endometrial tissue and endometrial cancer. Functional endometrial disorders. Dysfunctional uterine bleeding. Although abnormal uterine bleeding can be caused by well-defined pathologic conditions, such as chronic endometritis, endometrial polyps. Fig. 22, 20c. Some mucosal amyomas. See Fig. 22, 20d, or endometrial neoplasms, it most commonly stems from hormonal disturbances that produce dysfunctional uterine bleeding. Table 22.3. This is a clinical term for uterine bleeding that lacks an underlying structural abnormality. As discussed earlier, the normal body of uterus and endometrium 1003. 8b. CD Figure 22.20. Common causes of abnormal uterine bleeding. The most common is dysfunctional uterine bleeding. Seen here is anovulatory endometrium with stromal breakdown. No breakdown associated with proliferative glands. B. Chronic endometritis with plasma cells arrow. C. Endometrial polyp. D. Submucosal amyoma with attenuation of the endometrial lining arrow. Cyclical proliferation, differentiation, and shedding of the endometrium requires that all the involved pituitary and ovarian hormones be released at the proper time in the right amounts. Any disturbance of this finely tuned system may result in dysfunctional uterine bleeding, the most. For example, I3G22. B. Causer table sulfolamaramba and unityl B. Age group causes prepuberty, precocious puberty, hypothalamic, pituitary, or ovarian origin, adolescence, anovulatory cycle, coagulation disorders, reproductive age complications of pregnancy, abortion, trophoblastic disease, ectopic pregnancy, anatomic lesions, lamyoma, adenomyosis, polyps, endometrial hyperplasia, carcinoma, dysfunctional uterine bleeding, anovulatory cycle, ovulatory dysfunctional bleeding, for example, inadequate luteal phase, perimenopausal dysfunctional uterine bleeding, anovulatory cycle, anatomic lesions, carcinoma, hyperplasia, polyps, postmenopausal endometrial atrophy, anatomic lesions, carcinoma, hyperplasia, polyps. Common causes of which are discussed in the following sections. Anovulatory cycle. The most frequent cause of dysfunctional bleeding is anovulation failure to ovulate. Anovulatory cycles result from hormonal imbalances and are most common at menarche and in the perimenopausal period. Less commonly, anovulation is the result of the following: endocrine disorders, such as thyroid disease, adrenal disease, or pituitary tumors; ovarian lesions, such as a functioning ovarian tumor, granulosa cell tumors, or polycystic ovaries. See the ovaries section later in this chapter. Generalized metabolic disturbances, such as obesity, malnutrition, or other chronic systemic diseases. Failure of ovulation results in excessive endometrial stimulation by estrogens that is unopposed by progesterone. Under these circumstances, the endometrial glands undergo mild architectural changes, including cystic dilation, that usually resolve due to a subsequent ovulatory cycle. However, repeated anovulation may result in bleeding that, in certain clinical situations, may prompt an endometrial biopsy. In this setting, biopsies reveal stromal condensation and eosinophilic. 1004 Chapter 22 The female genital tract, epithelial metaplasia, features similar to those seen in menstrual endometrium. However, unlike menstrual endometrium, progesterone-dependent morphologic features, for example, glandular secretory changes and stromal predecidualization, are absent because the source of progesterone, the corpus luteum, does not develop without ovulation. Most commonly, the endometrium is composed of pseudostratified glands and contains scattered mitotic figures. See Fig. 22:20. More severe consequences of repeated anovulation are discussed in the endometrial hyperplasia section later in this chapter. Inflammatory disorders. The endometrium and myometrium are relatively resistant to infections, primarily because the endocervix forms a barrier to ascending infection. Thus, although chronic inflammation in the cervix is common and usually insignificant, it is of concern in the endometrium. Acute endometritis. Acute endometritis is uncommon and limited to bacterial infections that arise after delivery or miscarriage. Retained products of conception are the usual predisposing factors. The causative agents include group of hemolytic streptococci, staphylococci, and other bacteria. The inflammatory response is chiefly limited to the stroma and is entirely nonspecific. Removal of the retained gestational products by curettage and antibiotic therapy promptly clears these infections. Chronic endometritis. Chronic endometritis occurs in association with the following disorders: chronic pelvic inflammatory disease, retained gestational tissue, postpartum or post-abortion, uterine contraceptive devices, tuberculosis, either from miliary spread or, more often, from drainage of tuberculous salpingitis. Endometrial tuberculosis is rare in high-income countries. The diagnosis of chronic endometritis rests on the identification of plasma cells in the stroma. See Fig. 22:20b, which are not seen in normal endometrium. In about 15% of cases, no cause is apparent. Some women with this so-called nonspecific chronic endometritis have gynecologic complaints such as abnormal bleeding, pain, discharge, and infertility. Chlamydia may be involved and is commonly associated with both acute, for example, neutrophils, and chronic, for example, lymphocytes, plasma cells, inflammatory infiltrates. Irresponsible organisms may not be detected by culture. If infection is suspected on clinical grounds, antibiotic therapy is indicated even in the face of negative cultures, as it may prevent other sequelae, for example, salpingitis. Endometriosis and adenomyosis. Endometriosis is defined by the presence of ectopic endometrial tissue at a site outside of the uterus. The abnormal tissue most commonly includes both endometrial glands and stroma, but may consist only of stroma in some cases. It occurs in the following sites, in descending order of frequency: 1 ovaries, 2 uterine ligaments, 3 rectovaginal septum, 4 cul-de-sac, 5 pelvic peritoneum, 6 serosa of the large and small bowel and appendix, 7 mucosa of the cervix, vagina, and fallopian tubes, and 8 laparotomy scars. Endometriosis can have significant clinical consequences. It often causes infertility, dysmenorrhea, painful menstruation, pelvic pain, and other problems. The disorder is principally a disease of women in active reproductive life, most often in the 3rd and 4th decades, and affects approximately 10% of women. There are 3 types of endometriosis: superficial peritoneal endometriosis, ovarian endometriosis, and deep infiltrating endometriosis. Fig. 22.21. Superficial and ovarian forms of endometriosis are uncommonly associated with the development of malignancy, whereas it is extremely rare for the deep infiltrating form to undergo malignant transformation. B. Figure 22.21. Endometriosis. Endometriosis involving the mucosa of the colon. B. Higher magnification reveals endometrial glands and stroma adjacent to normal colonic mucosa. Body of uterus and endometrium. 1005. Pathogenesis. Fallopian tube. Uterus. The pathogenesis of endometriosis remains elusive. Proposed origins of endometriotic lesions fall into 2 main categories: 1, those that propose an origin from the uterine endome, endometrioticus trium, and 2, those that propose an origin from cells outside the uterus that have the capacity to give rise to endometrial tissue. The leading theories are as follows. The regurgitation theory proposes that endometrial tissue ovary implants at ectopic sites via retrograde flow of menstrual endometrium. Retrograde E. The benign metastasis theory holds that endometrial menstruation tissue from the uterus can spread to distant sites, for example, lung, and brain via blood vessels and lymphatic endometriotic implants channels. The metaplastic theory suggests that endometrium arises aromatase IL-1 beta directly from coelomic epithelium mesothelium of pelvis MMPs IL-8, IL-6 NGF or abdomen, from which the Mullerian ducts and alti, TIMP TNF alpha VEG PG may leave the endometrium itself originate during embryonic development. In addition, mesomphric remnants may activate it undergo endometrial differentiation and give rise to macrophages ectopic endometrial tissue. The extrauterine stem/progenitor cell theory proposes that figure 22.22 pathogenesis of endometriosis. Depicted is the interplay stem/progenitor cells from the bone marrow differentiate between factors expressed in endometriotic implants and activated into endometrial tissue. Macrophages that are hypothesized to play a role in the establishment and maintenance of endometriotic implants. Estrogen. Retrograde menstruation through the fallopian tubes is common, and the regurgitation theory provides a plausible explanation for the origin of ectopic endometrial tissue in the peritoneal cavity, which constitutes the vast majority. Inhibitors of aromatase are beneficial in the treatment of cases. However, it cannot explain endometriosis in women. Endometriosis, a link between inflammation and estrogen or amenorrhea because of a variety of underlying production, is made plausible by the ability of prostatiologies, for example, gonadal dysgenesis, endometriosis in the gland and to stimulate local synthesis of estrogen. And also urogenital tract of men treated with high-dose estrogens has been shown that retinoic acid produced in the stroma for prostate cancer and endometriosis in distant sites like cells promotes epithelial cell survival via paracrine signal of brain, lung, and bone. In addition, epigenetic alterations DNA methylation incidence of endometriosis, despite the common occurrence, have been described that lead to increased responsiveness of retrograde menstruation up to 90% of women, suggest to estrogen and decreased responsiveness to progesterone, that additional factors are involved in the pathogenesis of alterations that promote endometrial proliferation and the disorder. Survival. These abnormalities are present not only in molecular analyses have provided additional insights, ectopic endometriotic tissue, but also, albeit to a lesser, the endometriotic implants show certain differences when degree in the uterine endometrium of patients with compared to the endometria of women without endometriosis, suggesting that there is a fundamental triosis fig. 22.22. These include the following: defect in the endometrium, release of pro-inflammatory and angiogenic factors, including mutations in tumor suppressor genes and oncogenes, such as PG-EPO, IL-1 beta, TNF-alpha, IL-6 and IL-8, NGF, VEGF, MCP1, CRAS, PIK3CA, PPP-Pro-RON-A, and ARI-DUN-A, have been identified MMPs, and TIMP. Some of these factors are released via in the epithelial cells of deeply infiltrating endometrium-associated macrophages, which are recruited to triosis. The significance of these mutations in cancer driver endometriotic implants by pro-inflammatory factors, like genes, is unknown, but it is possible that they contribute metastatic tumors. The ability of endometriotic implants to the locally aggressive behavior of deeply infiltrating to survive and grow is dependent on angiogenesis, endometriosis. An association between endometriosis and which is mediated by typical pro-angiogenic factors, ovarian cancer of the endometrioid and clear cell types such as VEGF. Similarly, the ability to implant requires discussed later has been noted in a number of epidural modeling of the extracellular matrix, which has carried myologic studies with an approximate threefold increase out by factors such as matrix metalloproteases. These in women with endometriosis. These studies suggest the factors may also contribute to avoidance of immune common origin of abnormal endometriotic tissue and clearance. Ovarian cancers in some cases. Consistent with this idea, increased estrogen and retinoic acid production by endometriotic. In some instances, it has been shown that carcinomas harbor stromal cells, due in large part to high levels of the same mutations as associated endometriosis in the steroidogenic enzyme aromatase, which is absent in same patient, strongly supporting a pathogenic role for normal endometrial stroma. Estrogen enhances these driver mutations in the development of both the survival and persistence of endometriotic tissue in premalignant and malignant lesions. Chapter 22: The Female Genital Tract. Morphology. Endometriotic lesions bleed periodically in response to both extrinsic cyclic ovarian and intrinsic hormonal stimulation. This bleeding produces nodules with a red, blue to yellow-brown appearance on or just beneath the mucosal and/or serosal surfaces as sites of involvement. When lesions are widespread, organizing hemorrhage causes extensive fibrous adhesions between tubes, ovaries, and other structures and obliterates the pouch of Douglas. The ovaries may become markedly distorted by large cystic masses 3 to 5 cm in diameter filled with brown fluid resulting from previous hemorrhage. These are referred to clinically as chocolate cysts or endometriomas. Deeply infiltrating endometriosis can invade tissues and also cause fibrosis and adhesions. The histologic diagnosis of endometriosis is usually straightforward but may be difficult in long-standing cases in which the endometrial tissue is obscured by secondary fibrosis. The diagnosis is readily made when both endometrial glands and stroma are present. See Fig. 21b, with or without the presence of hemosiderin. In rare cases, only stroma is identified. If only glands are present, other diagnoses with different clinical ramifications, such as endosalpingiosis, must be considered. Atypical endometriosis, the likely precursor to endometriosis-related ovarian carcinoma, has two morphologic appearances. One shows cytologic atypia of the epithelium lining the endometriotic cyst without major architectural changes. The second is marked by glandular crowding due to excessive epithelial proliferation, often associated with cytologic atypia, producing an appearance that resembles complex atypical endometrial hyperplasia discussed later. Clinical features. Clinical signs and symptoms usually include severe dysmenorrhea, dyspareunia, pain with intercourse, and pelvic pain due to the intrapelvic bleeding and periuterine adhesions. Menstrual irregularities are common, and infertility is the presenting complaint in 30% to 40% of women. In addition, although uncommon, malignancies can develop within endometriomas, suggesting that these lesions contain at-risk epithelium. A related disorder, adenomyosis, is defined as the presence of endometrial tissue within the uterine wall myometrium. Adenomyosis remains in continuity with the endometrium, presumably signifying downgrowth of endometrial tissue into and between the smooth muscle fascicles of the myometrium. Adenomyosis occurs in up to 20% of uteri. On microscopic examination, irregular nests of endometrial stroma, with or without glands, are arranged within the myometrium. Like endometriosis, the clinical symptoms of adenomyosis include menorrhagia, irregular and heavy menses, colicky, dysmenorrhea, dyspareunia, and pelvic pain, particularly during the premenstrual period. It can coexist with endometriosis. Key concepts. Endometriosis. Endometriosis is defined as endometrial glands and stroma outside of the uterus. The ectopic endometrial tissue may bleed cyclically. Most common sites of endometriosis are within the abdominal cavity, but occasionally it is found at distant sites. Several theories: regurgitation, neoplasia, metastasis, and stem cell origin are proposed to explain the distribution of endometriosis. It commonly results in dysmenorrhea, pelvic pain, and infertility. Peritoneal and ovarian endometriosis may be a precursor to carcinoma, endometrioid, and clear cell carcinoma. 1006. Endometrial polyps. Endometrial polyps are exophytic masses of variable size that project into the endometrial cavity. They may be single or multiple and are usually sessile and relatively small, measuring 0.5 to 3 cm in diameter, but are occasionally large and pedunculated. Polyps may be asymptomatic or may cause abnormal bleeding and infertility. Cytogenetic studies indicate that the stromal cells in endometrial polyps contain acquired chromosomal rearrangements that are similar to those found in other benign mesenchymal tumors, suggesting that these lesions are best considered epithelial neoplasms. Polyps are responsive to estrogen but show little or no response to progesterone. See Fig. 22, 20c. Endometrial polyps may occur in association with the administration of tamoxifen, which is often used in the therapy of breast cancer due to its anti-estrogenic activity on the breast. However, tamoxifen has weak pro-estrogenic effects in the endometrium. Atrophic polyps, which mainly occur in postmenopausal women, likely represent the atrophic remnants of polyps that develop prior to menopause. Rarely, adenocarcinoma arises within endometrial polyps. Endometrial hyperplasia. Endometrial hyperplasia is an important cause of abnormal bleeding and a frequent precursor to the most common type of endometrial carcinoma. It is defined as an abnormal proliferation of the endometrial glands relative to the stroma, resulting in an increased gland-to-stroma ratio when compared with normal proliferative endometrium. Clinical, pathologic, and epidemiologic studies have pointed to the malignant potential of endometrial hyperplasia, and molecular studies have confirmed this relationship, as endometrial hyperplasia and carcinoma share specific acquired driver mutations in cancer genes described later. Endometrial hyperplasia is associated with prolonged estrogenic stimulation of the endometrium, which can be due to anovulation, increased estrogen production from endogenous sources, or exogenous estrogen. Associated conditions include the following: obesity, peripheral conversion of androgens to estrogens, menopause, polycystic ovarian syndrome, functioning granulosa cell tumors of the ovary, excessive ovarian cortical function, corticostromal hyperplasia, prolonged administration of estrogenic substances, estrogen replacement therapy. Body of uterus and endometrium. 1007. These are the same influences postulated to be of pathogenic significance in some endometrial carcinomas, discussed later. Inactivation of the 10 tumor suppressor gene is a common genetic alteration in both endometrial hyperplasias and endometrioid endometrial carcinoma. As discussed in Chapter 7, 10 encodes a lipid phosphatase that is an important negative regulator of phosphatidylinisyl-3 kinase PI3K/AKT growth regulatory pathway. When 10 function is lost, the PI3K/AKT pathway becomes overactive. Mutations in 10 are found in more than 20% of hyperplasias, both with and without atypia, and in 30% to 80% of endometrial carcinomas, suggesting that alterations in 10 occur at an early stage of endometrial tumorigenesis, although they are not predictive of progression of hyperplasia to carcinoma. Note, patients with Cotran syndrome, which is caused by germline mutations in 10, have a high incidence of endometrial carcinoma and certain other tumors, particularly breast cancer. As with many other tumor suppressors, it is not entirely clear why the loss of TEN, which is expressed in many tissues, is so highly associated with particular tumors. It is interesting to note, however, that PI3K/AKT signaling enhances the ability of the estrogen receptor to turn on the expression of its target genes. Thus, loss of TEN function may stimulate estrogen-dependent gene expression, leading to overgrowth of cell types that depend on estrogen for trophic signals, such as endometrial and mammary epithelial cells. Morphology. The classification of endometrial hyperplasia according to the World Health Organization, who includes two major categories, hyperplasia and atypical hyperplasia, also referred to as endometrial. Intraepithelial neoplasia, which differ in appearance and propensity to progress to carcinoma. Typical hyperplasia has a wide range of appearances, but the cardinal feature is an increased gland-to-stroma ratio. The glands show variation in size and shape and may be dilated Fig. 22, 23, although there may be back-to-back glands focally. Some intervening stroma is usually retained. See Fig. 22, 23b. These lesions are caused by persistent estrogen stimulation and rarely progress to adenocarcinoma, approximately 1% to 3%. Hyperplasia may evolve into cystic atrophy when estrogen is withdrawn. B. CD Figure 22.23. Endometrial hyperplasia, a typical hyperplasia. Note the architectural abnormalities including mild glandular crowding and cystic glandular dilation. E. Typical hyperplasia demonstrating increased glandular crowding with areas of back-to-back glands and cytologic features similar to proliferative endometrium. C. Atypical hyperplasia with further increase in glandular crowding and abnormal cytologic features. D. High magnification of atypical hyperplasia showing rounded, vesicular nuclei with prominent nucleoli arrow. 1008 Chapter 22 The female genital tract. Atypical hyperplasia. Endometrial intraepithelial neoplasia is composed of complex patterns of proliferation glands displaying nuclear atypia. The glands are commonly back-to-back and often have complex outlines due to branching structures. Individual cells are rounded and lose the normal perpendicular orientation to the basement membrane. In addition, the nuclei have open vesicular chromatin and conspicuous nucleoli. The features of atypical hyperplasia have considerable overlap with those of well-differentiated endometrial adenocarcinoma discussed later. An accurate distinction from cancer may not be possible without hysterectomy. Fig. 22, 23c, d. Indeed, up to 50% of women with a diagnosis of atypical hyperplasia are found to have carcinoma when a hysterectomy is performed. Currently, atypical hyperplasia is managed by hysterectomy or, in young women who desire fertility, the trial of progestin therapy and close follow-up. Most often, hopefully after a successful pregnancy, lack of regression prompts removal of the uterus. Key concepts. Endometrial hyperplasia. Endometrial hyperplasia is defined as an increase in the number of glands relative to the stroma, appreciated as crowded glands, often with abnormal shapes. It is most commonly caused by unopposed estrogen stimulation and is an important cause of abnormal vaginal bleeding. It is divided into typical and atypical hyperplasia based on nuclear morphology. Atypical hyperplasia is associated with an increased risk of endometrial carcinoma. The 10 tumor suppressor gene is mutated in approximately 20% of endometrial hyperplasias. Malignant tumors of the endometrium. Carcinoma of the endometrium. Endometrial carcinoma is the most common invasive cancer of the female genital tract. It accounts for 7% of all invasive cancer in women, excluding skin cancer. At one time, endometrial carcinoma was far less common than cancer of the cervix, but earlier detection and eradication of the precursor lesions of cervical carcinoma, coupled with an increase in endometrial carcinomas in younger women, have reversed this ratio. In 2019 in the United States, 61,880 new endometrial cancers and 12,160 deaths were predicted. Worldwide, there were over 380,000 new cases diagnosed in 2018. Pathogenesis clinical pathologic studies and molecular analyses support the existence of two broad categories of endometrial carcinoma referred to as type I and type Roman II, each with distinct risk factors, precursor lesions, molecular genetics, and clinical behavior summarized in Table 22.4. More recently, genomic sequencing of endometrial carcinoma has revealed four major molecular subtypes among endometrioid and Table 22.4 characteristics of type I and type Roman II. Carcinoma. Characteristics type I type Roman II. Age 55. 65 years 65. 75 years. Clinical setting unopposed estrogen atrophy. Obesity thin physique. Hypertension. Diabetes. Morphology endometrioid serous. Clear cell. Mixed Müllerian. Tumor. Precursor hyperplasia serous endometrial. Intraepithelial carcinoma. Mutated genes /10T53 genetic error done a regulator of aneuploidy abnormalities chromatin PIK3CA-PI3K. PIK3CA-PI3K FBXW7 regulator crossover MYC. Cyclin EFG-F12 growth factor CCN EN MGPPP pro RONA PP pro CTN and bone W and T signaling. POL T53 progressed tumors. Behavior indolent aggressive spreads via lymphatics intraperitoneal and lymphatic spread. a microsatellite instability, endometrial, serous carcinomas, the most common morphologies of type 1 and type 2 tumors, respectively. The salient molecular features of these four subtypes are as follows. Ultramutated/pol tumors, which are defined by the presence of mutations in DNA polymerase epsilon-pol that produce an exceptionally high burden of somatic mutations, the large majority of which are passenger mutations. Mutated/MSI microsatellite instability tumors, defined by mutations in or epigenetic silencing of mismatch repair genes, also leading to genomic instability and a high burden of somatic mutations. Copy number low/MSS microsatellite stable tumors, a common subtype also associated with endometrioid morphology that is frequently associated with mutations that upregulate signaling through the PI3K/AKT pathway. Copy number high/serous-like tumors, aggressive tumors with serous or high-grade endometrioid morphology that are often associated with T53 mutations and numerous genomic copy number variants. Endometrial carcinoma. This is the most common type of endometrial carcinoma, accounting for approximately 80% to 85% of cases. The majority of these tumors fall into the type I category. Most are well differentiated and mimic proliferative endometrial glands, features that are the basis for their name. As discussed earlier, it typically arises in the setting of endometrial hyperplasia, and like endometrial hyperplasia, is associated with conditions in which unopposed estrogenic stimulation. Body of uterus and endometrium 1009 of the endometrium occurs. Most notable of these is obesity, a rapidly increasing problem in high-income countries. The association with obesity underlies other conditions that commonly co-occur with endometrial carcinoma, particularly hypertension and type 2 diabetes. As with other cancers, development of endometrioid carcinoma stems from the stepwise acquisition of genetic alterations in tumor suppressor genes and oncogenes. In hysterectomy specimens containing both atypical hyperplasia and carcinoma, identical 10 mutations have been identified in each component, supporting the view that atypical hyperplasia is a precursor to carcinoma and that 10 mutations occur before the development of overt carcinoma fate. 24A. Sequencing of the genomes of endometrioid carcinomas has shown that the most common mutations act to increase signaling through the PI3K/AKT pathway, which is a hallmark of this particular tumor type. As mentioned earlier, PI3K/AKT signaling augments expression of estrogen receptor-dependent target genes in endometrial cells. Type I endometrial carcinomas are somewhat unique in that individual tumors may harbor multiple mutations that increase PI3K/AKT signaling, suggesting that tumor development and progression is fostered by successive increases in signal strength. Among the mutations that impact the PI3K/AKT pathway in endometrial carcinomas are the following. Mutations in the 10 tumor suppressor gene are found in 30% to 80% of endometrioid carcinomas. PI3CA, an oncogene that encodes the catalytic subunit of PI3K, harbors activating mutations in approximately 40% of endometrioid carcinomas. PIK3CA mutations rarely occur in atypical hyperplasias, suggesting that mutations in PIK3CA play a role in malignant transformation. Mutations that activate CRAS, which also stimulates PI3K/AKT signaling, are found in approximately 25% of cases. Loss-of-function mutations in ARI-DUN-A, a regulator of chromatin structure, occur in approximately one-third of tumors. Of interest, ARI-DUN-A is also frequently mutated in ovarian endometrioid and clear cell carcinomas, tumors that arise within endometriosis. Through unclear mechanisms, it appears that loss of ARI-DUN-A function also enhances pro-oncogenic changes in gene expression that are mediated by PI3K/AKT signaling. Other commonly observed mutations in endometrioid carcinoma disrupt genes that are required for the maintenance of genomic stability, presumably acting in part to create a mutated phenotype that increases the rate of acquisition of mutations in oncogenes and tumor suppressor genes. Defects involving DNA mismatch repair genes are found in about 20% of sporadic tumors and are particularly prevalent in endometrial carcinomas arising in women with hereditary nonpolyposis colorectal carcinoma syndrome (HNPCC), also referred to as Lynch syndrome, discussed in Chapter 17. Sporadic endometrioid, proliferative endometrium, non-atypical hyperplasia, atypical hyperplasia, grade 1 uterine endometrioid carcinoma, a myometrium, 10 ml home. CRAS microsatellite instability, ARI-DUN-A PIK3-CTNN bone FGFR12, atrophic endometrium, serous endometrial intraepithelial carcinoma, serous carcinoma, B, myometrium T53. Aneuploidy, FBXW7PPP12 RONA CCNEN. Figure 22.24 schematic diagram depicting the development of type I endometrial carcinoma and type Roman II endometrial carcinoma B. Most common molecular genetic alterations are shown at the time they are most likely to occur during the progression of the disease. MLHON encodes a component of the mismatch repair complex of proteins, and its loss of function results in microsatellite instability, found in about 20% of endometrioid carcinomas. 1010 Chapter 22 The Female Genital Tract. Carcinoma, loss of expression of DNA mismatch repair genes, is commonly caused by epigenetic silencing via promoter hypermethylation. Small subset, less than 10% of endometrial carcinomas have mutations that disrupt the proofreading function of DNA polymerase epsilon, encoded by the POL gene. These tumors have a remarkably high burden of somatic point mutations, possibly the highest of any human cancer. In approximately 50% of poorly differentiated carcinomas, loss of function mutations in T53 are present. Because T53 mutations are lacking in the vast majority of well-differentiated endometrioid carcinomas, these mutations are thought to be late events involved in tumor progression. Morphology. Endometrioid carcinoma can take the form of a localized polypoid mass or diffusely involve the endometrial lining. Fig. 22-25. Spread generally occurs by myometrial invasion followed by direct extension to adjacent structures/organs. Invasion of the broad ligaments may create a palpable mass. Eventually, dissemination to regional lymph nodes occurs, and in the late stages, distant metastatic spread to the lungs, liver, bones, and other organs may be seen. Endometrioid adenocarcinomas demonstrate glandular growth patterns that fall into three histologic grades. Well-differentiated grade 1 Fig. 22-25b, composed almost entirely of well-formed glands. Moderately differentiated grade 2 Fig. 22-25c, showing well-formed glands mixed with areas composed of solid sheets of cells, which by definition make up 50% or less of the tumor, and poorly differentiated grade 3 Fig. 22-25d, characterized by greater than 50% solid growth pattern. Well-differentiated tumors may be distinguished from hyperplasias by the presence of desmoplastic stroma or complex epithelial growth patterns, for example, confluent glandular or papillary growth patterns. Tumors with polymerase epsilon mutations or defects in DNA mismatch repair are frequently associated with large numbers of infiltrating T cells. It is believed that these cells represent an ineffective host response to neoantigens created by mutations that lead to tumor-specific amino acid substitutions in proteins. Up to 20% of endometrioid carcinomas contain foci of squamous differentiation. Squamous elements may be histologically benign appearing when they are associated with well-differentiated B, C, D. Figure 22.25 Type I endometrial carcinoma. Endometrial adenocarcinoma presenting as a fungating mass in the fundus of the uterus. B. Well-differentiated grade 1 endometrioid adenocarcinoma with preserved glandular architecture but lack of intervening stroma. C. Moderately differentiated grade 2 endometrioid adenocarcinoma with glandular architecture admixed with solid areas. D. Poorly differentiated grade 3 endometrioid adenocarcinoma with a predominantly solid growth pattern. Body of uterus and endometrium 1011. Adenocarcinomas. Less commonly, moderately or poorly differentiated endometrioid carcinomas contain squamous elements that appear frankly malignant. Current classification systems grade the carcinomas based on glandular differentiation alone and ignore areas of squamous differentiation. Serous endometrial carcinoma.